Good morning, ladies and gentlemen. Welcome to Biomedicine webinar series. This webinar is presented by Doctoral Program in Biomedical Science, Faculty of Medicine, Universitas Indonesia. Before we continue, I would like to introduce myself. My name is Dr. Rinda Saloka from Faculty of Medicine, Universitas Indonesia, as the Master of Ceremony in this webinar. As part of the visiting professorship program, this webinar will provide excellent learning materials and discussion from various experts around the world. Today, we will listen to a very interesting presentation from Dr. Fadia Kamal from Penn State University with the topic "An Antidepressant for Osteoarthritis, a Novel Modifying Research," and from Dr. Anna Aryana, Spesialis Penyakit Dalam, with the topics Treatment Approach of Knee Osteoarthritis, Update on Current Clinical Guidelines. Guided by Dr. Wawai Muli Arozal, Master of Biomed. As the moderator, we will listen to an interesting subject, which will open the participants' insight in biomedicine. Before we continue, I would like to reread about our term of conditions for all the participants. First, participants should present good manner during the event. Participants should left their microphone in mute condition. Participants are allowed to ask questions through Zoom chat by mentioning name and the institution. And participants are required to fill in attendance link twice to get webinar certificate. Attendance link will be posted 15 minutes after the opening and 15 minutes before the closing. This webinar would not have been possible without the support of DPBS as the forming institution. So then let's listen to remarks from the head of study program, Professor Asmarina. Professor Asmarina already joined us. Okay. I think Professor Asmarina is not ready to join us, so we will continue to our main section, which is topic presentation. Therefore, let me invite Dr. Wawai Muli Arozal to as our moderator to guide our discussion in this event in this morning. Good morning, Dr. Wawai Muli.
Okay. Good morning, Oka. Is my voice is clear?
Yes, Doc.
Okay, thank you very much, Oka. So, Assalamualaikum warahmatullahi wabarakatuh. Good morning to everyone and good evening to Fadia in US. So, welcome to our Biomedicine webinar series supported by Doctoral Program Biomedical Study Program, University of Indonesia. So, first of all, I would like to introduce myself. My name is Wawai Muli. I am from Department of Pharmacology, Faculty of Medicine, Universitas of Indonesia, and I will be responsible for hosting this presentation today. And I'm glad to welcome, we have two distinguished speakers today. The first speaker will be our clinical Department of Internal Medicine from Department of Internal Medicine, Rheumatology Division, Dr. Anna Aryana, Spesialis Penyakit Dalam Internal Medicine. And then the second speaker will be our guest lecturer, our distinguished guest lecturer, Dr. Fadia Kamal, PharmD, Master of Science, PhD, from Department of Orthopedic and Rehabilitation, Pennsylvania State University, US. So without further ado, I would like to invite our first speaker, Dr. Anna Aryana. So Dr. Anna, time is yours. Oh, okay. Maybe before Dr. Anna share her presentation, let me share her CV. So everyone can see. Okay. Dr. Anna Aryana was born on 1984. So now he's a staff member of Rheumatology Division in hospital RSCM. And then she has graduated from medical faculty in 2008, and then continue to get the specialist in internal medicine in 2014, and now also already get consultant specialty in 2019. So she has a lot of experience, mainly in rheumatology area, as well as also in osteoarthritis. Thank you. So now time is yours, Dr. Anna, to present your presentation.
Thank you, Dr. Wawaimuli, for your introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Thank you for the opportunity for inviting me in this very distinguished event. And today I would like to speak about clinical aspect of the osteoarthritis, while Dr. Fadia Kamal, our second speaker, will be talk about another aspect of the treatment. I would like to share with you some aspect of diagnosis on and the management of the osteoarthritis. Since, as I know from Dr. Muli, not all of the present participant here is a doctor. So let me introduce some aspect of the osteoarthritis. Dr. Muli, Dr. Wawaimuli, do you see my slide? Okay. A brief introduction about rheumatology. Rheumatology is one of the branch of the internal medicines. We're dealing with the rheumatic condition. Some of the rheumatic condition are due to the infection, like septic arthritis. If you want to know, some is about the metabolic condition like gout arthritis. Some are because of the degenerative process, like what we are talking here, osteoarthritis and also osteoporosis. Some of the trauma condition, but not needed for the surgical treatment, because if we need the surgical treatment, we will collaborate with our friend in the orthopedic department. The big portion of the outpatient clinic and also inpatient clinics are the rheumatic autoimmune disease. The first majority of the patient are SLA and the rheumatoid arthritis. We also have another kind of rheumatic autoimmune disease like spondyloarthritis, vasculitis, Sjogren, and other condition of rheumatic autoimmune disease. In our outpatient clinic, the first majority of the patient are RA, or rheumatoid arthritis. Second is SLE, lupus erythematosus, and the third is osteoarthritis. That's maybe it's just a brief brief introduction about the rheumatology. Now we are going to talk about the treatment approach of the osteoarthritis, but a little bit about diagnosis if you want to know. And I would like to compass with some clinical current guideline, international and Indonesian guideline of the osteoarthritis. Here also, I see in the participant, we have some rheumatologists join this event, like my senior Professor Jusjasri, Dr. Najirman, and Dr. Awalia. Thank you for joining. For osteoarthritis, you know that a few decades ago, we know that the osteoarthritis is only because of the mechanical damage. This is a degenerative process. But now this is a very big evidence that the osteoarthritis is due to the chronic inflammation, low-grade inflammation of the joint, of the local joint, so that we have the itis term osteoarthritis, which means this is an inflammation process of the joint. This is the most common rheumatic disease, most common musculoskeletal problem that we find in the outpatient clinic, and this is due to the degenerative process. And the condition will give you a feel of the pain in the joint, some stiffness, and also some joint will be swollen if the inflammation is very dominant. And osteoarthritis can affect all joint, but the most joint affect is finger. So we have osteoarthritis of the hand, and then the knee, and also the hips. The last is the spine. Most of the joint are the joint who is very actively used, and some of the weight-bearing joints like the knee and also the hips are the most common affected. And about some surveys see that in the rheumatic disease, 73% are suffer from the osteoarthritis. Osteoarthritis can be primary, only osteoarthritis, but osteoarthritis can be secondary to other rheumatic diseases like rheumatoid arthritis or other kind of disease in rheumatology, and then we'll end with the secondary osteoarthritis. Yeah, we don't have Indonesian number of the osteoarthritis. We just have a regional number. This osteoarthritis is present in the patient, yeah, mostly after 50 years, and will be increase in the age of over 65, and 80% of patient in the 75 of age will have the osteoarthritis, and most of it will have the knee as the main of the joint who affect by the osteoarthritis. And this is the incidence of osteoarthritis. Mostly are the knee of the female, and then followed by the hand of the female. Male is very male is not often, yeah, not more often in a if we compare with the female, yeah. So the female will be mostly affected by the osteoarthritis in the knee and in the hip and also in the hand. This is the osteoarthritis can be seen by the clinical judgment from the symptomatic, and also can be seen in the radiographic. If you see from the radiographic, we perform radiographic examination of the knee, for example, we will see about 25% adults older than 50 age have an osteoarthritis, but only 13% of them who have symptomatic manifestation, who have only 13 of them who have pain. So and hip also 11% from the radiographic we see already there is already changes of the osteoarthritis, but only 5% who have pain. Hand is very high discrepancies. 41% have radiographic changes of osteoarthritis, but only 3% have the pain. So there is not linear correlation within the radiographic examination and also the symptomatic manifestation of the osteoarthritis. Not all of the osteoarthritic joint in the radiology have pain in the clinical manifestation. Dear college, we have some risk factor of osteoarthritis. First is elderly woman, obesity, the joint have experienced injury before, and then doing a physical examination that can cause constantly mechanical damage, and family history of osteoarthritis. This is mostly in the hand of women. Mostly her mother also have the osteoarthritis of the hand, and then the risk factor is suffering from rheumatic disease like rheumatoid arthritis. We know that rheumatoid arthritis, if not well controlled, will make the joint to be deformed and the joint to be distracted, and we will have the secondary of OA after that. And other is a very small number of congenital or abnormality on cartilage, because the cartilage is the main problem in the osteoarthritis. Some of sign of the symptom of osteoarthritis is first is pain. If you don't have pain, you don't need to classify the patient to have osteoarthritis. You don't need to conduct some invasive management. So the first manifestation is pain of the joint, stiffness, but the stiffness is not quite long. It usually is less than 30 minutes in the morning. Some may be accompanied by the swelling, and also you will see the friction sound in the joint movement, actively or passively, and you may see the muscle of the weakening muscle around the joint. You may see the appearance of the spur or bony enlargement on the clinical physical examination, or you may see the spur on the radiographic examination, and you may see also other, sorry, this is bend of the finger if it affect the finger, like osteoarthritis of the hand. Some of the red flag that we have to see, if the patient have the pain and in the joint, you may further investigate, or you may refer to the specialty who are dealing with the osteoarthritis. You can refer to orthopedic, you can refer to internal medicine, some of the rehabilitation and medical rehabilitation. If you see that red flag, for example, progressive pain, and then pain at the rest time, and then stiffness more than 2 hours, be careful. Maybe this is not simple osteoarthritis, or maybe because this is not osteoarthritis. Maybe this is because of other kind of rheumatic disease, like inflammatory arthritis. So this, be careful with this kind of red flag that you may see. And then some of the comorbid or another disease that patient have, like HIV, patient with the condition of the immunocompromised condition. Sometimes it is said like osteoarthritis of the knee, but if we follow more, it is a septic arthritis, for example, in the immunocompromised patient. So we have to be careful for the possible serious underlying pathology like infection, cancer, fracture, or crystal arthropathy like gout, who will give you a more inflammation process other than osteoarthritis. And this is the knee, some brief demonstration of the knee joint, because the knee is the most prevalent joint affected by the osteoarthritis. This is the joint of the knee. If we see the blue one is the cartilage. The cartilage is the main pathology in the osteoarthritis. The cartilage doesn't have any nerve, doesn't have any vascular, doesn't have any lymphatic vein. But why did the patient of the osteoarthritis have pain? This is due to another process, another structure around the cartilage. For example, from the synovium, from the ligament, from the muscle, all of that will give you pain. And this managing this pain is sometimes very difficult. Like 1 or 2 modalities that we use in the treatment of the pain in the osteoarthritis sometimes doesn't give our good results. Sometimes the patient still have pain, still have a very bad quality of life. So that many things we try to do in the management of osteoarthritis, and Dr. Fadila Kamal will talk about the use of antidepressant. One of the things to interfere with the pain stimulus in the brain. So because managing osteoarthritis is sometimes not simple. Now this is the anatomic condition. The left side is the normal condition of osteoarthritis, and the right side is the pathology condition of the osteoarthritis. You may see that the cartilage, this is at this picture is pink. The cartilage is thinner, and then some erosion happen in the joint, like here. And because of the inflammation process, the synovial lining the joint also become inflamed and become thickened. Then this is will continue with the joint destruction and joint deformity. And this is the biomolecular process of how inflammation, low-grade inflammation happen in the osteoarthritis. You may see this is the cartilage. The cartilage will be degraded because of the some biomechanical, some instability, some damage, and there will be a microfracture of the cartilage inside of the joint, and this is will be continue the process of the inflammation, and so we will see that cytokine, pro-inflammatory cytokine like interleukin 1 will be increased in the synovial fluid. Some matrix metalloproteinase will be increased so that the degradation of the joint and the synovial will be happen in the osteoarthritic patient. This is the joint, knee joint. You may see the left side, the joint is swollen, and the right side, the joint is normal, but you may see that there's still bony, there is bony enlargement here around the joint, and here is the swollen joint. We can define which is, it is because the fluid, or it is because the mass, or it is because of the synovial hypertrophy. We can see from the physical examination, or if you need it, we can see from the ultrasound. We do ultrasound in the clinical practice to define is it fluid or not fluid, if it is needed. If you see, if you perform, we perform radiology in a knee to define grade of the osteoarthritis. The most severe is the grade 4, which is the joints space will very reduced. You may see the knee, the tibia, and the femur of the patient is almost kissing, yeah, no joint space. And you may see sclerosis. This is white in the subchondral area. And you may see also the formation of the spur, maybe we can see the more formation of the spur, the more joint space narrowing, the severe osteoarthritis. Now this is already severe. Yeah, we can see the deformity with the varus knee, yeah, and we see bony enlargement of the knee osteoarthritis. Here you can see the spur or bony enlargement in physical examination of the patient with the osteoarthritis. Here is the hip joint. You may see this is the joint space narrowing of the hip, and the space here is almost unseen. We almost cannot see the joint space of the hip. And then this is the osteoarthritis of the hand. You may see bony enlargement also in the distal interphalanx area and also the proximal interphalanx area. Here is the joint bony enlargement. Here is the bony enlargement. We call it with Heberden node. We call it with Bouchard node. This kind of sign of osteoarthritis of the hand. Here's also kind of osteoarthritis of the hand. And about the classification of the disease, about the diagnosis, we are benchmarking to the American College of Rheumatology. This is the criteria of osteoarthritis of the knee here in the left side. You may diagnose osteoarthritis by clinical only, or in the lower area, you may see by clinical and radiologic changes. The sensitivity is higher in the clinical, and the specificity is higher in the clinical and radiologic. You have to see if there is any pain, and you have to see that you see the crepitus, you hear the crepitus in a joint movement. You may see the stiffness less than 30 minutes in the morning. The age of the patient is more than 50 years, and then you may see bony enlargement. You may see tenderness in the bony, and then you don't see, you don't get swollen and hot warm joint, because if you see the warm joint, you have to think about other condition like gout arthritis or septic arthritis. So mostly in the osteoarthritis patient, even though we have swollen joint, the joint is not warm because the inflammation is very low grade and a chronic condition. So we rarely see a warm joint in the osteoarthritis. Diagnosis osteoarthritis, yeah, I already told you. Maybe I can proceed to another slide. Now, this is what we do in a clinical practice. If we see some swollen joint, we can perform with the ultrasound to make sure what the condition it is. Is there any injury of the soft tissues structure around the joint? We can see. And then if we needed to do some injection of the anti-inflammation like steroid, we do the injection here in the area of the joint affected, mostly are the knee. Okay, sometimes if you see the swollen joint, you have to define with it is the joint from the osteoarthritis or the joint from the gout arthritis or septic arthritis. So we perform the arthrocentesis. We aspirate the fluid in front in the joint, and then we analyze the fluid. Osteoarthritis will give you a clear yellow fluid like here in the left side, while inflammatory arthritis like rheumatoid arthritis, gout arthritis will be given in the more cloudy fluid, and septic arthritis is very purulent that you can see macroscopically, and it is will help you to do whether you want to proceed to injection of the steroid or not. If it is infection, of course, you won't do the injection of the steroid. Now we are talking about the treatment of osteoarthritis. Until now, we don't have cure treatment, so we don't target for the cure or normalize the joint, but we have to. But the target of the treatment of the osteoarthritis is pain reduction, maintain the mobility of the joint, prevent malfunction, improve the quality of life, and prevent the side effect of the drug that we use, and also prevent the complication. The main item, the main branch is non-pharmacologic treatment, pharmacologic treatment, and the surgery. This is some of the brief management of the osteoarthritis of the knee. We use as the basic is the exercise and education of the patient, and then the use of acetaminophen. And if it's not quite good result, we can proceed with the intra-articular corticosteroid, anti-inflammatory agent, or viscosupplementation. If it is not good result, we can perform arthroscopy from the orthopedic surgeon, and also total knee replacement if it is needed. This is some of brief management, and we will see and this is non-pharmacological condition, education of the patient, education of the weight loss, education of the exercise, non-weight bearing exercise, physical therapy, muscle strengthening exercise, and the use of proper footwear or some insole or joint protection that we needed, that it should be customized one by patient. I will proceed to the sum of the use of the pharmacological drug. Yeah, many of the evidence and the guideline already see that already give us proof that NSAID is very useful in the treatment of osteoarthritis. Non-specific NSAID or selective NSAID. Opiate is also used, and then non-opiate analgesic like acetaminophen and antidepressant is also used in the osteoarthritis. Some nutraceutical like glucosamine, chondroitin, and intra-articular injection like corticosteroid, hyaluronic acid, and PRP is already done for the osteoarthritis. But which one is good, which one is done, maybe it should be customized patient by patient, but we do have some guideline to be considered. Yeah. NSAID, we have NSAID who mostly inhibit the COX-1. We have selective COX-2. We have preferentially COX-1 inhibitor that can be used to relieve pains, to give rapid onset of action of the analgesic and to improve quality of life, but we are very often having side effect of the NSAID. That's the problem in the management of the osteoarthritis. Here is the NSAID we have non-selective NSAID. Like here, we have preferentially COX-2 inhibitor. If your patient have gastrointestinal risk factor, you may give the preferentially COX-2 inhibitor like diclofenac sodium, or you may give the selective COX-2 inhibitor like celecoxib or etoricoxib. And another analgesic with poor anti-inflammatory action, we can use the paracetamol or acetaminophen. This is some meta-analysis about the NSAID. Maybe I can proceed. The opiate like tramadol can be used as a therapeutic option in osteoarthritis. Many systematic review that the tramadol is very benefit for the osteoarthritis. But you may see that this is sometimes tramadol will give you a side effect gastrointestinal like nausea. So be careful with the side effect. And chondroitin and glucosamine. This is very controversial. We can see here later on the guideline that chondroitin and glucosamine is postulated to be act as chondroprotector or disease modifying OA drug to be and increase the concentration of chondroitin sulfate, but not all of the glucosamine chondroitin preparation. We have to see many studies that not all of glucosamine and chondroitin will give increased concentration of the chondroitin sulfate in the cartilage. And then it's also postulated to increase the other lubricants, reducing elastase activity, so it suppresses the collagen degradation and also suppress the inflammatory process. Diacerin is symptomatic slow-acting drug of the osteoarthritis. It is postulated to be act in the inflammatory cytokine on the prostaglandin, and lower the proteinase concentration, so that the degradation of the cartilage will be lower. Yeah. And then intraarticular injection, we have two intraarticular injection like steroid or hyaluronic acid. We can give the indication in the patient who do not respond to the conservative therapy like NSAID, a patient with severity like grade 1 or grade 2 osteoarthritis. Be careful with the patient who have hypersensitivity or septicemia condition or soft tissue problem like cellulitis or psoriasis. You may not give intraarticular injection. Or the patient with the intraarticular fracture or hemorrhagic diathesis, you may not give intraarticular injection. Corticosteroid injection or hyaluronic acid injection or platelet-rich plasma injection. These three injection and also prolotherapy injection, that is injection who can use in the osteoarthritis, but the most evidence is corticosteroid and hyaluronic injection at this time. Maybe we will have more evidence of the PRP, prolotherapy, and stem cell in the next decade. Corticosteroid, of course, it is act as an anti-inflammatory given in the osteoarthritis who have evidence of inflammation like joint effusion. Hyaluronic acid is replace synovial fluid, lubricant, and it is try to improve the biomechanical function of the joint. It is slow onset but long-term effect of the pain management in the osteoarthritis. This is the Eurofisco recommendation. This is from the Europe, yeah, about the management of Eurofisco recommendation about the fiscal supplementation of hyaluronic acid. This hyaluronic acid is recommended in the mild to moderate OA if the BMI or the BMI of the patient is less than 30. It can be given if the BMI is more than 30, but if the patient is not sufficient improved with the non-pharmacological intervention or in NSAID. In the advanced stage OA, the BMA is not less than 30. You may also give the vascular supplementation if the patient do not want to undergo the total knee replacement. So if the patient have a high BMI and then advanced stage of the knee OA, the effect of the viscous supplementation injection maybe is not good. So we have to we have to very consider which patient are given is intra-articular hyaluronic acid injection. Surgery is for the severe symptomatic OA, unsuccessful with the medical and physical rehabilitation treatment. It can be arthroscopic, osteotomy, or total knee replacement. This is some guideline of the osteoarthritis. Recommendation of knee osteoarthritis. This is the very long guideline in the 2000. Yeah, acetaminophen is the first, and you may also give the topical capsaicin cream. If inadequate, you may give the NSAID. If inadequate, you may consider for the arthroscopic and also the joint arthroplasty. This is the long guideline, and then this is the newest one, the EULAR from 2012. The EULAR recommendation give the treatment of OA should be combination of the pharmacological and non-pharmacological. Intra-articular joint injection is indicated for the acute exacerbation, only for the acute pain. And then there is evidence of Cisadoa at that time, glucosamine, chondroitin. At that time there is there is an evidence, but not much. And then hyaluronic acid and Cisadoa are probably effective at that time. And then non-pharmacological examination for the OA include regular education, exercise, and weight reduction. And then paracetamol and NSAID, and it can be used, and joint replacement can be used in the very severe osteoarthritis. Maybe we can go to the AAOS. AAOS is American Academy of Orthopedic Surgeons. They have some summary of recommendation. The strong recommendation is here in the green area, green block. Yeah, they recommend that the patient with symptomatic osteoarthritis should be participate in self-management program. So they have to be educated to exercise, to strengthening the muscle, yeah, and then reducing their weight loss so that the BMI is under 25. And they don't recommend using of the acupuncture at the time. This recommendation is in the 2013, and they do not have recommendation the using physical agent like electrotherapeutic agent, and they don't also have recommendation using manual therapy in the patient with osteoarthritis. AOS also recommend the using of the NSAID or tramadol in patient with osteoarthritis, and they don't have recommendation about the brace. They don't have recommendation about the using of the lateral wedges insole, and they strongly not recommend the using of glucosamine and chondroitin in the patient with the osteoarthritis. That's different things from the last guideline, yeah, the older guideline. They also don't have, we are unable to recommend the use of intra-articular injection. So some patient may be needed, some patient may not. So they don't have a strong recommendation at this field. They don't also have recommendation about the growth factor injection of the platelet-rich plasma, and they don't recommend using the hyaluronic acid for the patient with the osteoarthritis. Yeah, and this is our national guideline for Indonesian Rheumatology Association in 2014. Before we are using the treatment, the patient should be holistically approached using the you may assess his job, and then his activity, and then how much the pain, the comorbidity, disease, and other kind of social and patient related item you have to see before you are continue with the treatment. This is the diagnosis. The diagnosis, we use the classification from the ACR, like as I said before. Then this is the treatment. The treatment you may, from the ERA recommendation, we have to decide whether the osteoarthritis is mild to moderate or moderate to severe. If the mild to moderate, we can see the acetaminophen, and then topical capsaicin, NSAID, oral NSAID in the short term. Why you have to check the blood pressure and the creatinine for the side effect of the NSAID. If the very severe, you can give NSAID or opioid, or you may give the injection in the intra-articular like steroid to give a very rapid onset of the pain relief. This is the recommendation from the IRA, International Indonesian Rheumatology Association 2014. This is the ORC guideline. ORC guideline is the newest. ORC and ICR, we have the newest guideline in 2019. The strong recommendation is the education for the patient and exercise. This is not debatable. From the first guideline, the education and the exercise is the main point of the management. And then the pharmacological, we have topical NSAID, or non-selective NSAID, COX-2 inhibitor NSAID. The non-pharmacology is like aquatic exercise. The low consensus, but you may give, is like intra-articular hyaluronic injection, and then cognitive behavior therapy. And some of the pain, like here is for the widespread pain and depression, you may give the like duloxetine, some antidepressant that can give better improvement of the pain. This is the ORC guideline. So if the knee on osteoarthritis without comorbidity, you may give the biomechanic intervention, intra-articular steroid, topical NSAID, walking cane, or oral COX-2 selective inhibitor. If the knee osteoarthritis with comorbid, NSAID is maybe better than topical, and you may give intervention directly to the joint, intra-articular corticosteroid. The multi-joint, many joint like hand osteoarthritis without comorbidity, you may give oral COX-2 inhibitor, some antidepressant, analgesic. But if the multiple joint with comorbidity, you may be careful with giving NSAID, maybe only selective COX-2 inhibitor NSAID. And other modality are preferred other than NSAID. This is from the ESCO. ESCO is European Society for Osteoporosis, Osteoarthritis, and Musculoskeletal Disease. They strong recommendation also for the education and the exercise. Their weak recommendation using acetaminophen. Their strong recommendation for the prescribe of chondroitin and glucosamine. They also have strong recommendation for chondroitin sulfate, and then they have weak recommendation for the combination of glucosamine and chondroitin sulfate. And then also some strong recommendation using oral NSAID, weak recommendation using intra-articular of hyaluronic acid, and weak recommendation of using duloxetine, but it can be used in some patients who are not good beneficial effect of other treatment. This is the step by step. Yeah, step 1, if symptomatic, use the chronic Cisadua and then topical NSAID. And then if needed, using the knee braces, insole, or walking aid, and then Step 2 is pharmacological. You may see the GI risk as the consideration if giving NSAID. If the normal GI risk, you may give the non-selective NSAID. Increase GI risk, prefer COX-2 selective NSAID or selective NSAID with proton pump inhibitor. And then if still symptomatic, you may proceed to intraarticular hyaluronic acid or intraarticular corticosteroid. Last pharmacological attempt is short-term off-week opioid or duloxetine as an antidepressant. This is what recommendation said. And ORC and ESCO, it's not quite different. NSAID is the step 2. Step 1 is the education and exercise. Step first, maybe you can use the Cisadua or topical NSAID, while in the stage 3, you may use the hyaluronic acid or the duloxetine. And this is the last guideline that I will show you, ACR, American College of Rheumatology 2019, very strongly recommendation for exercise and self-efficacy and self-management program. And strongly recommendation for the pharmacologic is oral NSAID, topical NSAID, intraarticular steroid. If it is possible, guiding with the ultrasound or another imaging. And then strongly against, some study, a small study using bisphosphonate, glucosamine, hydroxychloroquine, methotrexate for the OA, but not quite good evidence. So it is strongly against in the guideline of the ACR. This is a summary, as you say, osteoarthritis hand, knee, and hip. Here it is strongly against. This is strongly recommended. Last slide maybe. This is hand, knee, and osteo and hip. Acetaminophen, duloxetine, tramadol, and non-tramadol. Tramadol, it can be used in 3 kind of osteoarthritis. And say intraarticular injection, intraarticular glucocorticoid injection is used in the knee and hip joint. This is the summary, and I proceed. This is the application. A brief about our application. If you have Android phone still, you may download the Rheumatology Indonesia. This is the application. You may see the criteria of the disease like lupus, or we have also osteoarthritis, hand and the knee. And you may also link to the some guideline of our rheumatology, Indonesian Rheumatology Association, and also guideline from the international. Mostly is from the ACR or from the EULAR. I think that's all my presentation. Thank you for the thank you for the opportunity. I will give the opportunity back to the Dr. Wabai Muli. Thank you, Dok. Assalamualaikum warahmatullahi wabarakatuh.
Okay, thank you very much, Dr. Anna Aryana. There is very comprehensive information from the epidemiology and then biomolecular pathology of OA, and then also clinical manifestation, diagnosis, and finally, Dr. Anna also mentioned about the treatment or management of osteoarthritis. She already mentioned there is a limitation, still limitation to manage OA by pharmacology approach because of, if I'm not mistaken, the goal of the treatment of the OA treatment is only for reducing the symptom. Is that true? Yeah. By using NSAID and then using acetaminophen, it only reduce the symptom, but not modify the progression of the disease. So there is a challenging to find a new drug that can modify the progression of the OA. So Dr. Anna already mentioned also the Cisadua is still controversial, yes, about the glucosamine, chondroitin sulfate, and hyaluronic acid also still controversial. Yeah, some guideline is not recommend this kind of drug. Okay, very nice presentation, Dr. Anna. So now we go to the second speaker. So Dr. Fadia, I would like to share the CV of Dr. Fadia. Oh, I'm sorry, I cannot find. Yeah. Okay, so Dr. Fadia Kamal is from Department of Orthopedic, Penn State College of Medicine, Pennsylvania, and then he was graduate from pharmacy in Lebanon. So your nationality is Lebanon, right?
Right. Yes.
And then she continue getting the clinical pharmacology from Niigata. So at that time, me and Dr. Fadia study together in Niigata, Japan. And then after that, she got many experience in research in US. So, and also very huge publication related to cardiac as well as also in OA field. So now Dr. Fadia has a huge grant also from National Institute of Health ongoing research support to find a new drug, yeah, for osteoarthritis. Very amazing, yeah. So okay, so Dr. Fadia will talk about the possibility of antidepressant to modify the progression of osteoarthritis. Okay, so this is kind of breakthrough modality treatment, yeah, I think. Yeah, because of Dr. Anna said that there is still limiting data for drug that can modify the OA progression. So please, Dr. Fadia, you can start your presentation.
Thank you, Dr. Wawaimuli, for the very nice introduction. I'm really humbled by this. And thank you for having me with you today. This is an honor to be with you. So I'm going to share my screen with you to start. And as Dr. Wawaimuli mentioned, we are investigating new treatments for osteoarthritis and, more importantly, disease-modifying treatments, because osteoarthritis, as Dr. Anna mentioned before me, is a degenerative disease of the joints. There is joint degeneration, and it affects more than 30 million adults in the United States. And it is the 5th leading cause of disability. People get disabled, they lose their jobs, and they are forced to be housebound when they reach late stages of osteoarthritis. It used to be thought that osteoarthritis is a matter of mechanical load and increased load on the joint, which is age-related. However, it's important to note that it is not only age-related. Osteoarthritis can hit young people. Any injury to the joint will lead to osteoarthritis eventually within a few years. If you tear a ligament, if you pop or tear your meniscus, this will lead to osteoarthritis in a few years. And there is a considerable number of young athletes in the United States and young people like college students who get injury just by practicing regular either professional or recreational sports, and they end up with osteoarthritis due to an injury. So, as I mentioned a few seconds ago, it used to be thought that osteoarthritis is a disease due to mechanical loading of the joint. But we know now that there are other cellular processes that lead to osteoarthritis. What is very important is that there is no treatment for OA, and the only option available for patients is pain management. As Dr. Anna mentioned before me, it's either NSAIDs or corticosteroids are the main 2 approaches for pain management. But even though statistics show that 50 to 70% of OA patients are not satisfied with their pain management, so they are still having pain, they are still having disability. And what happens on the cellular level is that In the cartilage, the cells that form the cartilage are called chondrocytes. And in osteoarthritis, these cells undergo a process called hypertrophy. I'm sorry. I'm sorry, you guys. Okay. So in osteoarthritis, the chondrocytes in the cartilage change their phenotype. They undergo a process called hypertrophy, which eventually leads to cartilage degeneration. At the same time, there is synovial inflammation, and there are also changes that happen in the subchondral bone sclerosis. So let's look closer at the cellular level. We have the cartilage and the chondrocytes, these cells living in the cartilage. As I mentioned, they undergo hypertrophy, they differentiate, and they become bigger in size. Not only do they change in size, their behavior changes. They secrete higher levels of matrix degrading enzymes. These enzymes, they are releasing the enzymes to the cartilage matrix around them. So technically, they are eating the cartilage surrounding them. And okay. So not only us, but also this has been a general approach in the field of osteoarthritis, which is to target these articular chondrocytes, which normally they are anabolic. They are in charge of maintaining the cartilage homeostasis by maintaining a balance between matrix degradation and matrix synthesis. So what these chondrocytes do, they are living in the cartilage continuously with time. They degrade a little bit of the cartilage matrix around them, and they synthesize new matrix and deposit it around them. So they are continuously replenishing this cartilage. This is under normal conditions. However, any injury or due to age, these chondrocytes undergo pathological hypertrophy. And what happens is that the balance is tipped off towards more matrix degradation. So these chondrocytes in OA, in osteoarthritis, they become catabolic and they destroy the cartilage. They degrade the cartilage around them. Eventually, this leads to cartilage degeneration, and these chondrocytes also eventually they die. Therefore, targeting this process, stopping or inhibiting chondrocyte hypertrophy, is a very attractive therapeutic approach or strategy for osteoarthritis. What is even better is not only to stop their hypertrophy, but also to bring them back to becoming normal chondrocytes, anabolic chondrocytes that build the cartilage around them. So in chondrocytes, since I work with the G protein coupled receptors, I looked at GPCRs in chondrocytes. And briefly, I want to mention that GPCRs constitute the largest protein superfamily. There are more than 800 members in the human genome. And very importantly, more than 50% of the drugs in the market target G protein coupled receptors. So we came up with the question of what do GPCRs do in articular chondrocytes? And when we looked into chondrocytes in general, we found that in the growth plate, during skeletal development, the chondrocytes and the growth plate are regulated by GPCR G-alpha subunit, where this G-alpha is very important to inhibit chondrocyte death. It also inhibits chondrocyte proliferation and differentiation and maintains the chondrocyte in a quiescent stage. This is what we want in the articular cartilage also. We don't want the chondrocyte to die. We don't want it to become hypertrophic. We want it living there in a quiescent phase, just replenishing the cartilage matrix around it. So at this point, we ask the question, what does GPCR signaling do in articular chondrocytes? And when I say articular, I mean the chondrocytes in the joint cartilage. And I want to mention here that in our previous work in cardiovascular and in kidney disease also, we found that there is impaired GPCR signaling that promotes cell hypertrophy and pathological remodeling in cardiovascular disease. You see the cardiomyocyte becomes bigger due to impaired GPCR signaling. So the question we asked about GPCR regulation osteoarthritis, I will answer it next, but first I want to give you a brief summary of the pathway that we discovered in heart disease and which we applied to the cartilage and osteoarthritis. So normally, a G protein coupled receptor or a GPCR is stimulated by an agonist, which leads to G-alpha activation and activation of downstream signaling, the physiological response of the GPCR. And in case of G-alpha-S, this will be elevated cyclic AMP levels. Now, as any signal in our cells, these signals need to be terminated. It needs to stop. It cannot keep on going forever, right? So the system to stop the signal is controlled by GRK2, which phosphorylates the receptor, recruits beta-arrestin to internalize the receptor. So GRK2 acts as a signal termination initiator. It is recruited to the cell membrane to phosphorylate the GPCR and internalize it in order to stop the signal through the agonist receptor interaction. Now, under pathological conditions, there are high levels of GRK2. So we found that in heart disease, there are high levels of GRK2 in the cell. And this GRK2 leads to continuous GPCR internalization and the loss of this physiologic G-alpha signal. So this leads eventually to hypertrophic signaling directly downstream to the elevated GRK2 as well. Therefore, elevated GRK2 levels, and I want to mention here that GRK2 is short for GPCR kinase. It's a kinase, it phosphorylates the GPCR. So elevated GRK2 levels desensitize the receptor and lead to the loss of the G-alpha cyclic AMP physiological response. And at the same time, it promotes hypertrophic signaling, direct hypertrophic signaling downstream. This, we discovered this in heart disease. But I'll bring you back here. So I mentioned to you in the last slide that dysregulation or the loss of the G-alpha-S signal is caused by high levels of GRK2. And we know that in the chondrocytes of the growth plate, G-alpha-S is important to inhibit cell death, inhibit chondrocyte death, and inhibit chondrocyte proliferation and hypertrophy. So here we asked, what if GRK2 is overactive in the chondrocytes in osteoarthritis? Are GRK2 levels elevated? Is this GRK2 diminishing G-alpha-S and leading to chondrocyte hypertrophy and leading to chondrocyte death? So to answer this question, we looked at samples, cartilage samples, knee cartilage samples from human patients, either normal patients who were undergoing amputation or MI meniscal injury patients. These are patients that had injured meniscus, torn meniscus, and they came in for surgery. And at the cartilage of patients with osteoarthritis that were undergoing a joint replacement surgery. So these meniscal injury patients, they represent patients with acute injury to the cartilage, while OA patients represent patients with chronic injury to the cartilage. And we found that when we looked at GRK2 expression by staining, and you can see it as the pink color, we found that there are much higher levels acutely following injury in the chondrocytes of cartilage And these high levels are maintained in the chronic osteoarthritis cartilage in comparison to normal patients. Now, we replicated the same thing in mice with osteoarthritis, and we found in the sham operated mice, which means more or less normal mice, they had very low levels of GRK2 expression in their articular cartilage. And this expression of GRK2, the articular cartilage here is denoted by these dotted yellow lines. The expression of GRK2 is increased following injury in a time-dependent manner. And the 12 weeks following injury, which is severe osteoarthritis, these mice had extremely high levels of GRK2. In mice, not only there was time-dependent increase in GRK2 expression, more importantly, there was a time-dependent loss of cyclic AMP production. So these chondrocytes that were having more GRK2 were actually producing less cyclic AMP. This takes us back to our hypothesis about the importance of a G-alpha-S and cyclic AMP signal in maintaining normal chondrocytes. So the second question we asked that, okay, if a GRK2 is elevated, leading to less G-alpha-S cyclic AMP signaling, which contributes to osteoarthritis, or if it is a major driver of osteoarthritis, is inhibiting GRK2 and the G-beta gamma GRK2 interaction. Does inhibiting this interaction attenuate chondrocyte hypertrophy? And to answer this question, we used a mouse model of osteoarthritis. In this mouse model, it's a post-traumatic OA model where we surgically go into the knee of the mouse and we transect the ligament that connects the medial meniscus to the tibia. So this leads to instability of the joint at the medial side, and mice start developing osteoarthritis with time. 6 weeks to 8 weeks following the injury, they are around mid-stage osteoarthritis, and after 8 weeks, between 10 and 12 weeks, they are late-stage osteoarthritis. So we operate on these mice to cause osteoarthritis, and then whatever manipulation we do, we started in the middle. We started at 8 weeks following surgery to replicate what happens in patients. You don't get a patient with no symptoms of osteoarthritis in the clinic. You get a patient with active osteoarthritis, which will be either early to mid or mid-stage OA. So what we did to determine the role of a GRK2 in the progression of osteoarthritis is that we used a conditional knockout model. And when I say conditional, and it's also inducible, so we can induce the deletion of the GRK2 gene specifically in the chondrocytes. If you look here with me, this is a control mouse, which means that a mouse that is not genetically modified. And this is a GRK2 conditional knockout mice where we could delete GRK2 specifically in the cartilage. You can see GRK2 is still in the bone underneath the cartilage as it is here, but most of the GRK2 in the cartilage is gone. And we deleted GRK2 at 8 weeks by injecting tamoxifen 1 week later, 1 week earlier in these mice. So we deleted GRK2 in mid-stage osteoarthritis, and we let these mice go until 12 weeks following injury, following this DMM surgery. And what we found is that in the mice that do not have GRK2, the articular cartilage surface was preserved. And I want to explain a little bit to you here about this staining. This staining is called saffron and orange fast green staining. What's nice about it is that it stains in orange color the cartilage matrix. So wherever you have mucins and proteoglycans that compose the cartilage, it will stain in orange color. Anything else like the subchondral bone or connective tissue will be green color. So this is a mouse that had the DMM surgery to induce osteoarthritis, and 12 weeks later, you see the extensive cartilage degeneration. All this green is remnant of the cartilage. All the cartilage is almost completely degraded. If you look here, you see that the cartilage surface is smoother. There is preserved thickness of this cartilage. You can even see the chondrocytes. These are the dark orange dots. And I'm going to talk about this next, but remember, it's very important that these chondrocytes are stained with dark orange around them. This has a very important significance. We'll talk about it next. When we want to quantify what's happening here, first of all, we do a scoring of the osteoarthritis degree. And we follow the ORC score. And when the score is higher, it means that the mice are having more severe osteoarthritis. In normal mice, the score is between 0 and 0.5. In OA mice, the score is more than 4. As you see here, it's around 4.5. When the mice lose GRK2, when we delete GRK2 in the cartilage, this ORC score goes down to about 2. Which is a very significant improvement and protection in these mice. When we quantified the cartilage area, we saw also a significant protection here. The knockout mice have more cartilage in comparison to the non-knockout mice. When we looked at the total chondrocyte number, we found also that the knockout mice have more chondrocytes, which indicates that GRK2 actually promotes chondrocyte death and loss. And when you delete GRK2, the chondrocytes are preserved and are protected from this death. So the next thing we looked at is the number of matrix producing chondrocytes. And these are the chondrocytes that I showed you in the slide before that had dark orange color around them. They have dark orange color around them because they are living in this cartilage and they are producing cartilage matrix components into the area surrounding them. That's why they stain dark for the cartilage matrix components, for mucins and proteoglycans, because they are anabolic. They are actively producing these compounds or molecules into the cartilage. When the number of matrix producing chondrocytes, anabolic chondrocytes, was also higher in the GRK2 knockout mice. And when we stained for aggrecan, which is the most important matrix component in cartilage, we found more aggrecan surrounding these cells. In this image, you can even see that there are more alive cells in this cartilage versus only few remaining here. When we looked at the levels of cyclic AMP, we definitely found in GRK2 mice, there is higher cyclic AMP production in the sham mice under normal conditions. They have about 70% more cyclic AMP production. And in osteoarthritis in DMM mice, when the cyclic AMP production declines to about less than 10%, by deleting a GRK2, we are recovering cyclic AMP production to about 60% of that of normal mice. So these chondrocytes, when they lose their GRK2, they are not dying. We're maintaining them alive. We're also maintaining them to be anabolic. They are producing, they are actively repairing the cartilage and building it. And we are recovering. This result is through the mechanism of GPCR, G-alpha-S, cyclic AMP production, because as we see, these chondrocytes have high levels of cyclic AMP. Now, the next thing we looked at is, okay, we cannot do gene deletion in patients, right? So we need a drug to inhibit this GRK2 instead of deleting it. So we looked at small molecule inhibition of a GRK2, and here we are either going to inhibit GRK2 directly, or we will indirectly inhibit receptor phosphorylation by GRK2 by inhibiting its interaction with the G beta gamma. Because at the GPCR, G beta gamma recruits GRK2 to the membrane to phosphorylate the receptor. So we had two approaches here. The first one is to use a drug called gallium, and gallium is a G beta gamma inhibitor. Gallium goes inside the cell, it binds to G beta gamma at the same spot where GRK2 binds. So when the GPCR is activated, GRK2 cannot be recruited to the membrane, and it cannot phosphorylate and desensitize the GPCR. The second approach was to directly inhibit the GRK2, and paroxetine binds to GRK2. GRK2 is recruited to the membrane, but still it cannot phosphorylate the receptor. So the net result is that GRK2 cannot phosphorylate the GPCR, it cannot desensitize the GPCR, which leads to recovered G-alpha S cyclic AMP signaling and attenuated hypertrophic signaling downstream to GRK2. So as I mentioned in the previous slide, we're using gallium as a G beta gamma inhibitor. It's an indirect GRK2 inhibition. We're using paroxetine as a direct GRK2 inhibitor. And gallium is known to have an anti-inflammatory effect. So we used indomethacin to control for the anti-inflammatory effect of gallium. We had a group of mice treated with indomethacin because we wanted to see if a treatment with this Nsaid can rescue osteoarthritis or not. And since paroxetine is an SSRI, paroxetine initially is an antidepressant. However, a few years ago, it was found that it also exerts GRK2 inhibitory effect. But in comparison to its counterpart fluoxetine, which is also an SSRI, that it lacks the GRK2 inhibitory effect. So we also had another group of mice that received fluoxetine only in order to see if the SSRI effect is also effective in osteoarthritis or not. And in our experiment, as I mentioned a few slides ago, we induced injury by DMM surgery. Sham mice were the normal controls. And 8 weeks later, when the mice are in mid-stage osteoarthritis, we started drug treatment and continued until 12 weeks, where the joints were harvested for analysis. And when we looked at these joints, it was very exciting to us because in both paroxetine and gallium-treated mice, we found that the articular surface was almost completely protected. And the chondrocytes were alive in the cartilage. You can look at the very dark staining around them, indicating that these chondrocytes are anabolic. They are actively repairing the cartilage matrix around them. If you look in these two samples, so this sample is a sham, is a normal sample. You can see the beautiful thick cartilage layer. Following injury, following DMM, at 12 weeks, the cartilage is almost completely lost. With paroxetine and gallium, if you look at this spot, this is the medial side. This is where injury started, here and here. And you can see that there is chondrocyte death. The chondrocytes died here because we waited until 8 weeks to start treatment. So at 8 weeks, there was already chondrocyte death at the medial side, at the site of injury. But in the vehicle-treated mice, this death signal and hypertrophic signal propagated through the whole articular surface. So all the chondrocytes were lost. But in paroxetine and gallium-treated mice, this signal was stopped. And the rest of the chondrocytes that were surviving, they were rescued and they became anabolic chondrocytes that regenerated the cartilage matrix around them. When we quantified the changes, we found increased ORSI score in the vehicle-treated mice and reduced ORSI score only in gallium and paroxetine-treated animals. There was very slight reduction with fluoxetine, the SSRI. With indomethacin, the Nsaid, there was almost no effect. This result was similar in the cartilage area. There was preservation of the cartilage with paroxetine and gallium treatment. There was no effect of fluoxetine or indomethacin, and same for the total chondrocyte number. It was reduced, however, more than half of the chondrocytes were rescued and preserved, in comparison to no effect with the SSRI, fluoxetine, or the Nsaid indomethacin. When we looked at the matrix-producing chondrocytes, we found also a significantly high number with paroxetine and gallium treatment, which correlates with what we saw in the staining, this dark coloration around the cells. With fluoxetine and indomethacin, there was no effect on matrix production by chondrocytes. We looked at aggrecan production also. We found that aggrecan production in paroxetine and gallium was even sometimes higher than the sham animals, again indicating an anabolic effect, which was also in parallel with recovered or preserved cyclic AMP signaling, taking us back to inhibition of the GPCR desensitization and preserving the G-alpha S cyclic AMP signal. So from here, we looked a little bit more at the cellular level, and we found, of course, we wanted to confirm that GRK2 expression is actually reduced by these treatments, which was the case. You see increased GRK2 expression in the vehicle-treated OA mice in comparison to normal mice, and this GRK2 expression was reduced by both paroxetine and gallium treatment by GRK2 inhibition. We looked at the chondrocyte hypertrophy markers, namely ADAMTS5 and MMP13. These are the enzymes that are secreted by the chondrocyte to degrade the cartilage around them. And the expression of these enzymes is increased in osteoarthritis because this is what causes cartilage degradation and degeneration. With both paroxetine and gallium, there was a significant reduction in MMP13 and ADAMTS5 expression. So this means the chondrocytes are becoming less hypertrophic. They are degrading the cartilage less. And as I showed you in the previous slide, they are making more aggrecan. They are repairing and regenerating the cartilage more with paroxetine and gallium treatment. The last thing we looked at is aggrecan neo, which is a breakdown product of aggrecan. So in osteoarthritis, when these chondrocytes are secreting high levels of MMP13 and ADAMTS5, they break down aggrecan, they degrade it, leading to the production of the aggrecan neo product. With paroxetine and gallium, there was less aggrecan neo expression, indicating less cartilage degradation. The next thing we wanted to know is whether this effect is limited to cartilage, because remember, in the beginning of my presentation, I mentioned to you, and Dr. Anna also mentioned to you, that osteoarthritis is defined by degeneration of the cartilage, but it also involves other part of the joints. We have inflammation of the synovium. The synovium becomes thicker, becomes inflamed, and we have changes in the subchondral bone. There's subchondral bone sclerosis. There's increased angiogenesis here. There's also increased nerve supply with increased blood supply, which some people say this leads to pain in osteoarthritis as well. So we looked at the synovium to see if synovial inflammation is changed or not. And we also looked at the bone, the subchondral bone. When we looked at the synovium, we analyzed the synovial thickness, and you can see that there is a significant increase in the synovial thickness following osteoarthritis in the DMM mice that were vehicle treated. But with paroxetine and gallium treatment, there was a significant reduction in the synovial thickness, indicating less synovial inflammation. With fluoxetine, there was a mild effect as well. And with indomethacin, there was, of course, an effect on synovial inflammation because indomethacin is an NSAID. It is supposed to inhibit inflammation. And actually, fluoxetine is reported to inhibit inflammation in rheumatoid arthritis as well. So what was very interesting is that when we looked at the knockout mice, the GRK2 knockout mice, which had protected cartilage, their synovium was still inflamed. So this shows us that in the GRK2 knockout mice, although their synovial inflammation is not changed, their cartilage was protected because GRK2 was deleted or inhibited. So this leads us to a conclusion that the role of GRK2 in chondrocytes is a driver of osteoarthritis. Next, we looked at the bone in these mice, and we had some concerns because paroxetine and galion showed to have an anabolic effect on the cartilage. What if they are also anabolic in the bone? They may actually lead to more osteophyte formation if that's the case. So we looked at bone sclerosis and osteophytes, and we actually found, as you see here in the micro-CT images, there is significant, first of all, significant osteophyte formation. This is the femur, and this is the tibia. This is the medial meniscus. This is the medial meniscus that we injure. In the sham mice, you can see it is well-defined, very nice and clean. The joint space is clean. There's no osteophytes. The surface of the bone in the femur and in the tibia is very smooth. Following osteoarthritis, 12 weeks following DMM in mice, the meniscus becomes mineralized because of the injury that we caused. The femur, if you look here at the femur, there's a lot of roughness indicating osteophyte formation. In the tibia also, there's a lot of roughness here. Even we can see more roughness when we look at several different layers of the micro-CT, again, indicating osteophyte formation. With paroxetine and galion treatment, osteophytes were less. The whole remodeling process was slowed down. When we quantified the knee bone volume, because increased mineralization or increased osteophyte formation will reflect in increased bone volume, as you see in the vehicle-treated DMM mice. With paroxetine and galion, there was a trend towards reduction with significant reduction in the galion-treated mice. It was close to the normal mice. With osteophyte number, we found also a significant increase in the OA mice that were vehicle treated, and this was significantly reduced by galion and paroxetine. Next, we also looked at the subchondral bone. We found that the subchondral bone mineral density, which was increased in the OA mice, was reduced by galion and paroxetine, and the subchondral plate thickness. So the subchondral plate is it's a layer of bone. You can see it here by the red line. It's a layer of bone that is directly underneath the cartilage, and it's kind of a transition between the cartilage and the bone, the trabecular bone that's in the subchondral space. You can see in the normal mice, it's a thin layer. Following osteoarthritis, it becomes thick, and with paroxetine and galion treatment, the subchondral bone is maintained thin. The subchondral plate is maintained thin, and if you look at the subchondral bone, you can see the bone marrow spaces. They are very nice here. Following osteoarthritis, they become very narrow. There's less bone marrow spaces. This was also preserved by galion and paroxetine. So we found that paroxetine treatment or GRK2 inhibition protects the cartilage, prevents inflammation, and exerts positive effects on the subchondral bone as well. The last piece of data I will show you is using a human OA cartilage, because as we all know, the problem, not the problem, but this is a negative point, one of the cons of preclinical research in animals, is that it does not always translate to human tissues. It does not, what we find in the lab does not always happen in the clinic with patients. So what we did, we wanted to see if a GRK2 inhibition also can rescue human chondrocytes. So we took the cartilage from patients undergoing knee replacement surgery, osteoarthritis patients, and we cultured it as osteochondral plugs. So we didn't isolate cells. We took the whole cartilage and we cultured it ex vivo for 48 hours. We treated with either vehicle, gallium, and paroxetine to inhibit GRK2. And we found that with gallium and paroxetine treatment, there was a reduction in the production of MMP13 and ADAMTS5, indicating reduced chondrocyte hypertrophy, similar to what we found in our studies in the mice. So from here, I will move to our conclusions. I would like to present this picture, which is our last figure in the paper. It's actually in the supplementary figures. It shows the difference between the normal and the OA cartilage and the difference in signaling. So in normal cartilage, the GRK2 levels are under control, the cyclic AMP levels are high, the chondrocytes are anabolic, they are maintaining the cartilage around them. In osteoarthritis, GRK2 increases, leading to less cyclic AMP, and the chondrocytes become more catabolic. With paroxetine or with gallium, the phosphorylation of the receptor, this phosphorylation is inhibited, and the chondrocytes are restored to an anabolic phenotype. Therefore, we propose that by inhibiting GRK2, we can prevent cartilage degeneration and at the same time attenuate synovitis and subchondral bone changes, representing a novel OA therapy through GRK2 inhibition. And at the end, of course, all this work wouldn't have happened if not for the hard work of my lab team and my collaborators. Please feel free to ask any questions.
Okay. Thank you very much, Dr. Fadia. So very interesting presentation. So it's kind of a story from you find the GRK signaling and then you searching the treatment that can inhibit the GRK2. So and then finally you can prove it in vitro as well as also in vivo that GRK2 inhibition can modify the progression of OA by reducing the hypertrophy in cartilage. Okay, so I think there are many questions from our participant. So the participant can ask question by directly to the speaker, either to Dr. Anna and to Dr. Fadia. Is there any question from the participant? So if I'm not mistaken, there are also many colleagues from rheumatology division. Dr. Zulhasril. Yeah. Okay, so very interesting. So, okay, maybe Dr. Anna. Oh, okay. Okay, maybe I will ask a question first. So related to Dr. Fadia. So I'm confusing you use paroxetine for inhibition of the GRK2. So is there any relationship between serotonin and the hypertrophic in cartilage?
So there are no studies that show any role of serotonin in osteoarthritis. In our paper, you will see in the supplementary data that we looked at the expression of serotonin receptors, different serotonin receptors, and we looked at the expression of the serotonin transporter also, because the SSRIs, they target the serotonin transporter. They inhibit the serotonin transporter to increase serotonin level at the synapses. We found that these are expressed in the cartilage, but their levels, some of them are expressed, not all the serotonin receptors, like a couple, because there are 7 types and subtypes of the serotonin receptors. Some of the receptors were expressed. The serotonin transporter was also expressed, but their expression was not changed in osteoarthritis.
Okay. Okay, it means not all the SSRI have inhibition to GRK2, You mentioned only fluoxetine. Yeah, okay.
Only paroxetine. That's why we also used fluoxetine. And we showed that fluoxetine does not have an effect, indicating that SSRIs do not really affect chondrocyte hypertrophy. It reduced inflammation, but it did not affect chondrocyte hypertrophy. It did not rescue cartilage degeneration. Only paroxetine did that, and it's due to GRK2 inhibition rather than SSRI effect.
I see. Okay, thank you very much. So there is a question from the participant from Melva. So Dr. Fadia, I would like to ask about the safety of the antidepressant drugs regarding to the tolerability and possibility of dependence. Because of if we use paroxetine for a long period, so maybe it will cause some side effects. So what is your opinion about that?
Sure. Well, paroxetine, like all drugs, it has side effects, right? So our role, I believe, as clinicians, maybe to start with the least dose possible and see if this dose generates effect on the cartilage of patients, and not watch also for the side effects, of course, especially that paroxetine has a black box warning, right, with the suicide. So we need to be very careful with patients, start with low doses, the lowest dose possible, monitor during the first 2 to 4 weeks for any suicidal thoughts, these most dangerous side effects, and monitor the side effects with time as well.
Okay, so maybe the dose is different, yeah, for antidepressant doses and for anti-osteoarthritis. Maybe the dose is...
Yeah, maybe, especially that if you think about it, for an antidepressant, you need it to go to the brain, right?
Yes.
So it needs to be in high concentrations to cross the blood-brain barrier. But if you just want it to get to the peripheral circulation, we can get away with low doses. We hope so. We have a clinical trial in the pipeline, so we will see what happens there.
Okay, thank you very much, Dr. Fadia. So next question from Prof. Lee. Maybe you can ask by yourself, Prof. Lee.
Yeah.
Hello, good morning. My name is CJ Lee, and I'm from Kamal National University in South Korea, and I'm working in UI as a research right now. So,
hi, nice to meet you.
It's really interesting, and my question is about the binding affinities about the paroxetine, because, well, the first question also is about the paroxetine side effects. So I would like to ask you about the binding affinity of paroxetine to GRK2 or serotonin transporter. So,
do you mean like the affinity or specificity?
Both, like, because well, I'm a little bit curious about the dosage when we can.
Yeah. So I can send you the paper. It was not done by us. The paper was produced, I think, in 2014 by a medicinal chemist who they did screening for a library of drugs, and that's how they found that paroxetine is a GRK2 inhibitor. It has high affinity to GRK2 and high selectivity to GRK2 versus other GRKs as well. So it does not bind to other GPCR kinases. It specifically binds to GRK2. Now, if you want to compare between its affinity to serotonin transporter versus GRK2, I don't believe that was studied, in that it is not reported in that paper. So I'm not sure about that. But what we did, we used clinically relevant doses. And you can see in our paper, we analyzed the blood levels of paroxetine, and they were paroxetine and fluoxetine, and they were within the therapeutic levels as an antidepressant.
Okay, and I have a second question to Professor Kamal. And the another thing is, you treated 4 weeks, right? After you made the model. So, and I'm a little bit concerned about the period, because this is an inhibitor of the GLK2. So if you treat it more than 4 weeks, like 8 weeks or like 3 or 6 months, what could be happen in the cartridge? So because it is because the GLK2 need to desensitizing GPCR signaling pathway, right? So it could not. What happening there?
Right. But so this is the difference between inhibiting and deleting a protein, right? We're giving a drug. Paroxetine will go inside the cells. It will bind to GRK2, but again, it will be washed out by the blood, and it will be excreted, right? So I'm guessing the dose and the frequency of dosing plays a role here, and it should be controlled. And again, I would think in a clinical setting, we would want to start with the lowest dose and lowest frequency possible to avoid any systemic effects of GRK2 inhibition, as you mentioned also.
Okay, I see. And I have a question to Professor Anna. Can I ask her? Okay. Recently, there's some concerning about the cardiovascular side effect treated by Nsaid, especially diclofenac and selective COX-2 inhibitor, right? So may I ask you, how about you manage the cardiovascular side effect when you treated the diclofenac or selective COX-2 inhibitor?
Yeah, thank you, Prof. Lee, for your question. In the clinical practice, we have we have some recommendation for giving NSAID, considering the GI risk factor and also cardiovascular risk factor. In the patient with the clinical risk factor of the high risk of the cardiovascular risk factor, but without gastrointestinal risk factor, if the pain is severe, we can still giving the COX-1 inhibition. So the COX inhibitor who are mostly inhibit the COX-1, like the old NSAID, like ibuprofen, we have, but we still have to maintain to monitor the blood pressure and also the others of cardiovascular marker. But if we have the high risk cardiovascular risk factor and also high risk GI risk factor, we don't give NSAID. We don't give any NSAID for this patient. We are using another modality, like using acetaminophen or like using non-opioid tramadol. And then for the selective COX-2 inhibitor, there are recently any big study for the celecoxib. Celecoxib, I forgot the name of the study. Yeah, they are looking for the side effect of the cardiovascular effect. In this term is the raise of the blood pressure. If it is compare with the ibuprofen, they said that it is similar, but we still have to be careful using this kind of selective COX-2 inhibitor in a very, very high risk cardiovascular patient. Maybe that's what can I answer. Dr. Wawaimuli, may I ask Dr. Fadia Kamal? I'm curious about the continuing clinical study of this paroxetine in GRK2 inhibition in the patient with the osteoarthritis, because that's the study you shared is in the in vitro study. Maybe how you proceed for the in vivo study that we can, and then make this is a clinical treatment for patient.
You mean clinical trial?
Yes, clinical trial.
So we have in the States, at least, I don't know in Indonesia, but in USA, we have to get the FDA approval for any clinical trial. And we currently submitted our paperwork to the FDA. We plan to start with patients with traumatic injury to the knee, because these are, the easiest patients to follow. They are more controlled population of patients. And later on, we can work on patients with more progressive or mid-stage osteoarthritis. Yeah. And again, as I mentioned, we plan to study with the lowest dose and lowest frequency in order to minimize side effects as much as possible. And of course, monitor our patients, especially during like the first 2 to 4 weeks period. Monitor them for any changes in the mood, any suicidal thoughts, because this is the most scary thing. Yeah.
At this time, do you already start the clinical trial in the patient? Like you said, in the trauma.
We're waiting for the FDA approval, and we should get it within this month, within March. Yeah.
Yeah,
but then we have also more paperwork to do because there's a lot of regulations in the States.
Okay, thank you, Dr. Fadia.
Yeah, you're welcome.
So maybe we can create a multi-center clinical trial, yeah, Dr. Anna, because we have a lot of patient in Jakarta. Is it true, Dr. Anna?
Yeah, if it is possible, I'm so happy to. If you need it, I'm so happy. Yeah, we have many patients with osteoarthritis, primary or secondary osteoarthritis.
Sure, we can talk more about it in the future for sure.
Okay, so there is also a question from the audience, from Melva. Maybe you, Melva, you can ask by yourself. Melva?
Yeah, thank you, Dr. Muli. Maybe also Dr. Muli can also answer. Dr. Fadia, have you tried any candidates maybe from the natural products previously on this GRK inhibitors?
No, we have not, but this is very interesting to us. And I remember discussing this with you ladies during our meeting. This will be very interesting to pursue together since you have a library of natural products, right? And you have also screening abilities in the labs. That will be really exciting.
Okay, thank you, Dr. Fadia. Maybe Dr. Muli can answer.
Okay, Fadia, I'm concerned about your animal model. So you use a DMM, if I'm not mistaken. So in Indonesia, in our lab, so we develop OA by injection to the knee. Monosodium, I forgot the monosodium. What kind of monosodium? Injected to the, apa ya Melva ya?
Glutamate.
So so we
monosodium glutamate
to the knee, and then it will develop osteoarthritis. So I think it is not clinically similar with in human. Yeah. So can you explain detail about your animal model?
Sure. So the DMM model in the studies with osteoarthritis, preclinical studies, the DMM model is considered the most clinically relevant. There are other models where they do meniscectomy. They remove the meniscus completely. But these other models, they progress very quickly. The DMM model is similar to clinical settings because it progresses slowly relative to other models. Like if you look at 8 weeks, you will not find much cartilage degeneration. 8 weeks following injury, you will find some cell death, a little bit of fibrillations. You will not see cartilage degeneration before 10 weeks. And at 12 weeks, you can see extreme cartilage degeneration. With other osteoarthritis models, like when you inject the compound you were talking about, you get cartilage degeneration within 4 to 6 weeks, right? Yeah, and also other surgical models like meniscectomy models or the ACL transaction model, they progress really fast. So they do not resemble what happens in patients. So far, the DMM model is the most clinically relevant. Of course, it's more time consuming because you have to wait 3 months, and it's more expensive because you have to house the mice and do everything for 3 months. But the results are more clinically relevant than other models.
Okay, thank you for, maybe we will learn from you how to develop the animal model.
Sure, no problem at all. Thank you for your question.
There are many students here, PhD students, they don't have any research topic. Maybe this one is very interesting topic. Okay.
Sure.
So next question, maybe Fadia, related to the distribution of the drug to the knee, to the joint. So, I mean, the paroxetine should be have high distribution, so it can be directly to the synovial.
Yes, yes. We don't have, I mean, recent studies have shown that almost all compounds, I mean, we use also tamoxifen to induce gene deletion. And we inject tamoxifen, it gets to the knees, we see the gene, we see the recombination in other models, in other fluorescent recombinant models, we see it happening very quickly. We also have some in vivo imaging experiments that we did where you label with luciferin, and we can see that when we inject either by IP or subcutaneous injection, the molecules or the compounds get to the joint space very quickly, and they actually clear quickly also. Like the clearance time in the joint space is between 30 minutes and 1 hour in our experiments, not longer than that. So yes, to answer your question, when it's injected by IP like we did with our mice, it is distributed, it goes to the circulation, into the joint space, and then it is cleared within a couple of hours maximum.
Oh, sorry, the paroxetine is in injection, not in oral.
Yes.
Yeah. Oh,
for mice, we do IP injection.
IP, yes. Oh, okay.
But in patients, human patients, they will take it by tablets, oral tablets or capsules.
So you plan, I mean, in clinical trial, you will plan for oral or
yes.
oral?
Oral, for sure. Yeah.
Okay. Thank you. Yeah. Okay. Any question from the participant? Dr. Anna, maybe. Okay. So there is some question, long question from Kania. Kania, maybe you can ask by yourself. Kania Indriani.
Wait.
Kania, please.
Okay.
Okay.
Thank you, Doctor and Prof. Kamal. I'm Kania Indriani. I'm actually still a medical student in University of Indonesia. So basically, my question is, it really interests me that this specific effect was manifested when we use paroxetine. And a few years ago, and I know paroxetine is indicated as a short-term treatment for a post-traumatic stress disorder. And also, there's another article that I read a few years ago that GRK2 was the GRK2 downregulation hold a significant role in mediating brain damage and lowering pain threshold in mice. So, and I know these two pathogenesis has a possible is hypothesized in the pathogenesis of PTSD. So, do you think this GRK2 can be a model that bridges the psychiatric and immunological responses toward life-threatening injuries? Have you or your colleagues ever found any research exploring similar topics? Thank you.
Thank you for your question. It's very interesting, and I appreciate your deep research in the topic also. Unfortunately, I don't have much information about GRK2 in the brain and about bridging the psychiatric and immunological responses. I'm sorry, I don't have much information on this, but this definitely triggers my curiosity to read more about this topic. It's very interesting. But I want you to take into consideration also is that you mentioned the brain GRK2 downregulation in mice, right?
Yes.
Has a significant role in mediating brain damage. If they are doing genetic deletion, again, This is different from inhibition with a drug, because a drug goes into the cells and then it's cleared. The protein expression is not affected. But with genetic downregulation or genetic deletion, you are losing the protein. And what's important here is that the protein, like GRK2, is known to interact with so many molecules inside the cell, upstream and downstream to it. With paroxetine, we know that paroxetine binds to the catalytic side of GRK2. It inhibits its interaction with the receptor and the phosphorylation. We don't know yet much about how it affects other functions of GRK2, but I would imagine that other functions of the GRK2 will be preserved, like some of them, if not all of them. But when you perform genetic deletion, you are removing the protein completely. So all the interacting partners with this protein, all the processes that the protein regulates are being affected. So there is a big difference between genetic downregulation and small molecule or drug inhibition.
All right. Thank you very much, Professor.
Thank you for your question.
Okay, there is also one question from Prof. Lee. Dr. Kamal, if you treat both NSAID and paroxetine, co-administration NSAID with paroxetine, is there any possibility to get the synergistic effect?
Yeah, so as we all know, and as Dr. Anna mentioned, NSAIDs are used in osteoarthritis, but they are not really that effective. Their effect can be short-term, and with progressive OA, they aren't that effective also. In our animal study, we found that paroxetine had an equal anti-inflammatory effect to the NSAID indomethacin. So I wouldn't really expect a synergistic effect because both of them are inhibiting inflammation. So it wouldn't really add anything to combine an NSAID with paroxetine.
Okay, thank you very much, Fadia. So is there any question from the participant? So maybe I would like to ask to Dr. Anna. Yeah, so you mentioned about the use of topical capsaicin. Yeah, so this is also in guideline. So the evidence base of the topical capsaicin is good, or what is your opinion about that?
Yeah, topical capsaicin may relieve the pain in some mild pain of the patient, and this is due to the hot sensation of the topical topical capsaicin. So it is it is in some guidelines the topical capsaicin is still can be used, Dr. Wawai Muli, in the mild and long-term treatment of mild pain.
You know that the main compound, the chemical compound of chili is content of capsaicin, if I'm not mistaken.
Yeah. So the sensation of the hot may reaches the sensation of the pain of the patient. That's the mechanism, not because of the capsaicin will be absorbed into the intraarticular, not that kind of mechanism.
Yeah. So it is kind of menthol, yeah. Okay, thank you. Yeah. So this is only for mild, mild OA.
Yeah. At this time, actually, we are conducting a clinical trial with Japan. We are now doing clinical trial of the patch of the NSAID patch in the knee of osteoarthritis, because we are trying to use NSAID oral as short as possible, as short term as possible, because many side effects. So yeah, we are now conducting clinical trial for the NSAID patch, and maybe next year I will or in the December, yeah, in the end of the year, maybe we can see the result, Dr. Wawai Muli.
Oh, that's very good. Yeah, I mean, it will reduce the side effect of the NSAID. Yeah, because it will be slow release. Yeah.
Yeah.
Slow release. Yeah. So maybe we only use one patch for a week. No. One patch for a week.
Yes, one patch for a week, and we are comparing with the gel of the NSAID gel.
Ah, I see. Yeah. So, like a diclofenac gel. Yeah. Okay. Yeah. This also for mild to moderate OI. Yeah, I think. Yeah. Okay. Yeah. Any question from the audience? Dr. Kamal, so can you, so maybe many of our students interest with your published paper. So can you share again your published paper, your recent published paper, including the supplement in this Zoom, I mean, in the chat. So there are about 90 participants. Oh. Okay, thank you very much.
Again, I'm sending the main text and the supplementary material also.
Yes, so everyone, everyone can download the full paper, the published paper of Dr. Kamal. So in our student, in our PhD student, maybe some of our students interest to do postdoc in your lab. It is possible or not? Or sometimes we can.
Yeah, I am very happy to communicate with them and see the opportunities available.
Yeah. Okay. Yeah. Okay. Thank you very much. So, any question from the others before I close this meeting? So, I think in US already 12 o'clock or 11.
It's 10:30.
Okay. Yeah. Okay, so if there are no questions from the participant, I'm very happy to guide this webinar session. So thank you again for Dr. Anna, your very interesting presentation, and again for our guest, Dr. Kamal. Maybe after this session, we will have intense communication. I mean, to create collaboration research between Faculty of Medicine, Universitas Indonesia, and your Pennsylvania State University. So as I already mentioned, or Anna mentioned, we have a lot of OA patients, yeah, in Jakarta, yeah. So maybe we can create some multi-center study here. So again, thank you very much for the participant for joining this webinar. I hope you can enjoy, and then you can get a lot of knowledge and information. I also thanks to the committee, to the doctoral program, Biomedical Science, to create this prestigious seminar. So I will close this meeting. Thank you again, Dr. Anna and Fadia Kamal, and all the participants. Good day, and then happy to all of you, and then stay healthy. Bye-bye. Assalamualaikum warahmatullahi wabarakatuh.
Thank you for having me. It was a pleasure. Thank you so much.
So I will go back to the MC.
Before we end our discussion, let we take the picture together. So all participants, please turn on the camera, and we will wait to take the picture. Okay, 1, 2, 3. One more time. 1, 2, 3. Okay, I think that's all. Thank you for Dr. Fadia Kamal, Dr. Anna Aryana, and Dr. Wawai Muli for the presentation and the very interesting discussion. Let me share. And we are very happy to listen to the osteoarthritis topic and its novel studies about the treatment, the new treatment for the osteoarthritis. Okay, thank you very much. We are finally arrived in the end of the session. I remind to all participants to fill in the attendance link before leaving the Zoom meeting. I, representing webinar committee, apologize to any mistakes and shortcomings during the webinar. Thank you for your coming. See you in the next webinar series.
Thank you.
Everyone.
Thank you.